Yeah, we'll be live in 10 seconds.
So, Rolika, how long should I speak?
45 minutes, 50 minutes.
Till you finish your lecture.
30 to 40 minutes, no problem.
Sure, sir. Sure.
Okay, Santosh, 30 to 40 minutes.
45 minutes is what we give.
Okay.
That's.
We are live.
Good evening. Today is a very special episode of iFocus Online. Today is the 150th episode. We never stopped it. We started it at the peak of COVID, and we have continued it every Wednesday and Friday for 150 episodes non-stop. No holidays for iFocus. So we have the pleasure of having Dr. Mahipal Sachdev, who is the originator of the idea, to welcome you all today because it's a special episode.
Good evening, everyone, and welcome to this special session on iFocus, the 150th session. And I think this has gone from strength to strength. iFocus over the last several years that we had the physical meeting, but this time the idea definitely came when the COVID struck, that we should not leave behind the academic exercises because people needed to be constantly engaged. And obviously with the less of clinical work, this was also a time for people to become academically strong. And I think what we have seen is the successful implementation by Santosh of this every week, having it twice a week and then going on to the 150th episode. If we look at the number of people viewing this to begin with, whenever this is streamed, it is about 500-600 people who view it, but within a week it becomes 4,000 to 5,000. So that is the kind of strength and the draw which iFocus is having. And I think this is the least that Center for Sight, which wants to actually give back to the ophthalmologists in form of clinical, making them learn clinically, and making them learn academically. I think this is something that we are really very thankful to Dr. Santosh for having brought this on. I think Santosh is doing it's really very, very painstaking that a person has to be doing this twice a week and to spend the time all through and getting more and more people to watch this. So Santosh, I think kudos to you. Kudos, I would say, to all the people who make these presentations, because this is what enthuses the residents, the fellows, and even ophthalmologists to go on. But I think the most important is the people who tune in and who listen to these particular lectures, because there is a lot of questions that come in and there are a lot of appreciation that is coming in for this particular program. I'm sure that sooner than later we will be able to hold this in the physical form. But till such time that we are able to hold this in the physical form, I think these lectures, which are obviously available on YouTube also, will serve as an excellent guide to people who are preparing for their exams, those who have already given their exams and want to refresh their academic knowledge. And this 150th episode, which is Retina number 2, is by none other than Dr. Aniruddha Agarwal, who is at the Cleveland Clinic, which is a fantastic facility. I did happen to be there once at Abu Dhabi, and he's going to be talking on applied physiology of the retina and choroid. And we have two master retina people, actually 3 of them just now that I can see. That is Dr. Dinesh Talwar, Dr. Ajit Babu, both from AIMS RP Center, and then Ajit went on to LVP, and both of them are at Center for Sight, Delhi and Hyderabad. And then we have, I would say, the Gen Next, somebody who is doing exceptionally well in retinal surgery, and that is a very safe pair of hands, Dr. Ritesh Narula, who is from GNEC and then LVP. So they will be going ahead and also contributing in this particular session. And thanks, Rolika, for being there for this particular session. So without much ado, I would wish to say again, thank you all the audience for listening on to the iFocus series. And thank you, Santosh, once again for really putting this together, which is indeed an exceptional and a brilliant job that you're doing. Thank you.
Thank you so much, sir. Thank you for the strength that you give to focus and for the wind beneath the wings. So I'll request Dr. Dinesh Talwar to introduce Anirudh. Here is the very abridged biodata.
Good evening, ladies and gentlemen. Welcome to iFocus. This is the second in the series of retina lectures. The important thing is that if you know clinical work, but you don't have a foundation, you really find yourself floundering very often. But if your foundations are strong, you can always think back to the origins and find out why a particular problem is occurring. And any problem solving requires you to go back to the roots. The roots come in retina from the anatomy, then the physiology, and understanding both leads you to the pathophysiology. Without the physiology, without the knowledge of the physiology, you will find that you can be a good technician, a good technologist, but not a great clinician. And if you want to be a great clinician, you have to strengthen the knowledge you have of physiology of the subject. And for that, today we have Dr. Aniruddha Agarwal, who got his basic training from postgraduate PGIM at Chandigarh. And after his training in Chandigarh, he has done a lot of research, has published over 200 peer-reviewed manuscripts. He is the editor of a book on uveitis. I have been interacting with him very frequently from the time he's been a student, and I find he's one of the very brilliant minds we have, a person who goes to the gist of the matter, to the roots of the matter. And I believe that he's probably the best guy we have today to teach us about the physiology of the retina, and also not only to teach you all, but to help us all of us here, brush up our knowledge of the physiology of the retina. Over to you, Anirudh. Please go ahead.
Thank you very much, sir, for the kind introduction. Thank you to Dr. Mahipal Sachdev and to Dr. Santosh Honawar, sir, for this kind invitation. And I think with this, I'd just like to dive straight into my topic, which is applied retinal physiology, as well as physiology of the choroid. So if you can confirm if my slides are visible, please.
They are visible.
Yes, sir.
Thank you. So the functions of the retina are, as we all know, very basic, that it needs to absorb the photons of light and translate the light into a biochemical message. All of these biochemical messages are then subsequently translated into electrical impulses, and which go to the brain via the ganglion cells. And you may have realized how we have in this slide included a number of items, which is photoreceptors, the RPE cells, and ganglion cells. And this is how you can see the applied anatomy and physiology of the retina works based on these three important cell lines. But one of the most important and critical elements in the retina and the choroid is the retinal pigment epithelium, the RPE, which is responsible for a number of issues such as absorption of light, transepithelial transport, spatial buffering of the ions, visual cycle, phagocytosis, secretions, and we'll talk about what are the secretions by the RPE and the immune privilege of the eye. Now, among all of these, you can see from this slide that RPE does have a very significant role in the photoreceptor functioning as well. So it is not only secreting VEGF, anti-VEGF, the drive for the anti-VEGF and other molecules, but it is also responsible for a number of activities such as transepithelial transport and buffering of the ions, which are necessary for your visual functioning. This is a very basic diagram which shows you the light entering from the pupil and it is getting absorbed by the RPE cell line. It's a monolayer, as we all know from the anatomy lecture probably. And this absorption of the light photons causes an increase in the temperature, which is transported by the blood vessels into the choriocapillaries. Now, the choriocapillaries layer is one of the highest perfused tissue in the body. It has a relative blood perfusion which is higher than that of the kidneys even. So it's one of the highest perfused tissues because it is responsible for a very delicate function of the visual acuity maintenance. In addition, there are a number of pigment cells which are responsible for absorption of light, and these are the melanosomes, carotenoid pigments such as the lutein and zeaxanthin. And we've heard of these names now. A lot of you must have heard as postgraduates in, when you're talking about therapy for age-related macular degeneration. So all of this comes from basic physiology. You have these molecules responsible for absorption of light energy. In addition, there are a number of antioxidants which are located in the retinal tissue, specifically the RPE. And these include ascorbate, alpha tocopherol, beta carotene, glutathione, and melanin. Remember, all the light which is hitting the RPE and the photoreceptors, all of this can damage the DNA. And this DNA damage can be very, at a very rapid rate. And these cells, therefore, have a natural ability to repair damaged DNA, lipids, and proteins. This is extremely important for the structural integrity of the RPE and the photoreceptor layers. The functions of the RPE are very, maintained in a very tight manner by the epithelium. In addition, there is a paracellular resistance and a transcellular resistance, which leads to maintenance of the function. Remember, RPE also transports the nutrients and ions between the photoreceptors and the chorocapillaries, which relies on transepithelial transport. And therefore, in conditions such as where you have an RPE atrophy, for example, you have chronic CSR, or if you have dry AMD, you have loss of RPE. In these patients, you will also have dysfunctional photoreceptors because the nutrition of the photoreceptors suffers. Two important transport mechanisms that happen in the RPE are glucose transport and all transretinol transport. The transport of the glucose is facilitated by two important transporters, GLUT1 and GLUT3, and the molecule which is all transretinol is transported by a receptor-mediated process, and this is extremely important when you are facing, physiology tests such as examinations such as FRCS, and they'll all ask you the importance of transportation of all transretinol, which is a receptor-mediated process. So you have serum retinol binding proteins or transthyretin complex, which then is able to transport the all transretinol. Now, docosahexaenoic acid is an important molecule which is essential for renewal process of photoreceptor outer segments. So when you have the outer receptor segment shedding, which happens during the visual cycle, we'll talk more about that. You have docosahexaenoic acid, which is very important for renewing the outer segments. So this is synthesized in the liver and transported in the blood bound to plasma proteins. And it's taken up in a concentration dependent manner. Now, photoreceptor pigments may basically composed of retinine, which is an aldehyde of vitamin A, and opsin, which is a protein. Now, the opsin protein has different amino acid sequences in different pigments. So it's a family of proteins. You don't have a single opsin, but it's a family. And when you have a combination of the rod pigment, which is the retinine, with the scotopsin, this is called rhodopsin. Why is it scotopsin? As the name suggests, scotopsia is dark. So the rod pigment in the resting phase is in the dark phase. When you don't have bright light stimulation, is called rhodopsin. The neural circuitry of the retina is very simple. So you have the light which is hitting the RPE and the photoreceptors. These photoreceptors will send a signal to the bipolar cells, and the bipolar cells transmit through the ganglion cells finally onto the brain. So this is a three-step pathway: photoreceptors, bipolar cells, and ganglion cells. And this is then transmitted to the brain. This is one of the very simplest diagrams that you can find of the visual cycle, the Wald's visual cycle. Now, the Wald's visual cycle is not so simple, actually. It's broken down into a number of steps. And starting from the stimulation of light, you have the change of rhodopsin to a number of intermediary molecules, and finally you have metarhodopsin 2. This metarhodopsin 2 what it does is it facilitates the activation of transducin, which causes the cyclic GMP to becomes monophosphate GMP, and these ion channels, they close and they have a reduced oxygen demand, and that's when the electrical stimulus is generated. Meanwhile, when you have the light stimulus, the retinal pigment, which is in the cis isoform, is converted into transretinal. And this transretinal is converted into retinol and then into esters, and then by the RPE65 back into cis-retinol, which is then isomerized into cis-retinal. So you have a number of steps here which involve, it's just an isomerization of a number of these molecules from retinal configuration to retinol configuration, and then you have cis and you have trans configuration. And at the same time, this change from cis to trans, helps in release of energy, which converts rhodopsin to meta-rhodopsin 2. Now, the rhodopsin cycle, whenever you have light energy, will convert it into a number of enzymes. So you have bath-rhodopsin, lumirhodopsin, meta-rhodopsin 1, and meta-rhodopsin 2. And remember, any defect in any of these levels can be responsible for genetic diseases of the visual pathway. So you can have defects from conversion of bath-rhodopsin into lumirhodopsin, and that's a genetic defect which can be responsible for retinitis pigmentosa and its number. So retinitis pigmentosa family has a number of gene defects, and one of these can affect the conversion of bath-rhodopsin into lumirhodopsin. Now, the moment you have meta-rhodopsin 2, what it does is it converts the all-trans retinal into all-trans retinol. And these, by the isomerase enzyme, can be converted into 11-cis retinal. And this releases energy, as I said, for the electrical stimulation. And meta-rhodopsin 2 will escape out as a scotopsin and then back into rhodopsin in combination with the 11-cis retinal. Now, among the functions of the RPE, some of the most important thing is it not only provides like a structural integrity of photoreceptors, but it also secretes enzymes. And the two most important ones are the pigment epithelium derived factor, PEDF, which protects against the hypoxia and glutamate induced apoptosis of the photoreceptors. And it also secretes ciliary neurotrophic factor, which protects the photoreceptor cell death. So you may have heard now a number of agents, and in fact, pharmaceutical agents have been developed in the field of glaucoma, which are neurotropic factors, which are neuroprotective. They basically function by this pathway, which is a ciliary neurotrophic factor pathway, CNTF. It also secretes members of the fibroblast growth factors. The choroidal endothelium, in addition to the RPE, secrete VEGF, which is the most important molecule for vascular diseases of the retina, such as age-related macular degeneration and DME, in addition to retinal vein occlusions. And this is the vascular endothelial growth factor, but it also secretes the TIMP, which is tissue inhibitor of matrix metalloproteases, which stabilizes the extracellular matrix and prevents neovascularization. Now, moving on, we know that in addition to these molecules, you have a very important aspect in the RPE and the photoreceptor layer and the choroid is the complement system. The complement system functions similar to the system in the body elsewhere. And when you have an oxidant exposure, so when you have exposure to peroxides, which are endogenous and oxidant molecules, or when you have exogenous damage, you can have an oxidative stress, which results in DNA damage. And DNA damage causes an inflammatory cascade mediated by interleukin 6 or 8, which secretes the neovascular molecules such as VEGF. Now, remember, when you have the complement pathway activation in patients who are genetically predisposed, such as complement factor H patients, you can have the cycle set for development of age-related macular degeneration. So a complement system also contributes greatly to the development of diseases in the choroid and in the retina. And the simple thing we're talking about is choroidal neovascularization. Coming to vascularization, I think one of the most important part of physiology of the retina and the choroid is the vascular physiology. And often this is not discussed because the vascular physiology is very complex to understand. And in this part of the lecture, I will be talking to you with some case examples to make it more interesting and to see how you can apply your knowledge of physiology to actual patients. Now remember, in the retina, you have plexi of capillaries, and these capillaries are arranged in a laminar pattern. So you have well-defined layers, and the deep plexus communicate with the superficial layer, and you have short precapillary branches. These branches are vertical to the plane of the capillaries. Now, these laminar patterns, by the time we have development of the embryo, the arrangement of the capillaries in different layers already starts. So as you see in the figure A, this is from the IOVS paper 94, you can see that you have beginnings of the capillaries in the superficial retina, and you can see that in the black arrow on top, on the top right. So these capillaries start in the superficial retinal layers like the ganglion cell layer, because the ganglion cell layer, we know, is very actively involved in the photoreceptor functioning and signal transmission. Subsequently, these capillaries branch out and develop deeper vessels, and you can see in the panel B, you have an arrow which is pointing out to a precapillary loop, which is down connecting to the plexus down below. Now with OCT angiography and projection artifact removal, we know we have distinct capillary plexus which are superficial and deep, and till 2017 we believed that you have only the superficial and deep plexus. But now when you have a combination of knowledge from anatomy and physiology and OCT angiography, we know that there is an intermediate plexus also. From the point of view of physiology, it's very important to understand that the superficial plexus is within the ganglion cell layer, and that's the first to develop embryologically. The deep plexus is at the outer edge of the nuclear layer, outer edge of outer nuclear layer, and the intermediate is on the inner edge of the inner nuclear layer. So you have, now talking about these three plexuses, so when you have the arrangement of the capillaries in three different plexuses, remember the attachment or the connection between the plexuses are not very well developed. And you have vertical vessels which connect the superficial to the intermediate to the deep vessels. And they all supply not only the photoreceptors, but also some of the structural cells such as the RPE, amacrine cells, which have mainly function as cells which are responsible for the structural integrity, also the bipolar and the ganglion cells. Now, when you have ischemia of these layers, they can be categorized as three components. So you have cotton wool spots, which is ischemia of the superficial capillary plexus. You have ischemia of the deep capillary plexus, which is now called as PAM, but it's basically an infarct of the inner nuclear layer. And you have outer macular neuroretinopathy, acute macular neuroretinopathy, which is ischemia of the deep capillary plexus also, but you have outer retinal involvement, which is outer plexiform layer, outer nuclear layer, and beyond. Now, combination of PAM and AMN is called as deep retinal ischemia. Now, why this is important is because the blood supply of the retina and choroid has number of physiological important aspects. So in an article by Sohan Singh Hare on the retinal and choroidal vascular supply, and this is published in Indian Journal of Ophthalmology, I think in 2018. So if you get a chance, all of you, please go back, read the article by S.S. Hare. He's from Iowa City, and he has published extensively on retinal and choroidal vascular supply. And he says even one single cotton wool spot in the retina is significant because it represents ischemia, and this is an ischemia of the superficial capillary plexus. So this is an example of a cotton wool spot in front of your eyes there. You can see in the peripapillary region. Now PAM, or basically an inner nuclear layer infarct, is an ischemia which affects the deep capillary plexus, and it can happen because of two conditions, which is high outflow pressure or low inflow pressure. So this is where physiology comes into play. So you can have high outflow pressure in venous occlusion, and that can happen in CRVO, where you have a venous occlusion. And you can have a low inflow pressure in arteriolar occlusion, such as emboli, arteriolar occlusion, or hypoperfusion. Now, this is one case example here of a male who has scotoma and headache, and you can see a hypopigmented lesion in the nasal macula. On infrared, it is hypo again. And on fluorescein angiography, you have ill-defined hyperfluorescence in the late phase. On OCT, there is hyperreflectivity of the layers, which is involving both the inner and the outer nuclear layers. So you have the ganglion cell layer, which is also affected. And OCT angiography shows you hyporeflectivity there. And this patient had vascular migraine on MRI and MR angiography, and you have a PAM lesion. So now we call it PAM. But even 30 years ago, we all know that this is an infarct of the inner nuclear layer. So the message that I'm trying to convey is, for all the residents, postgraduates, and fellows, do not be confused by terminology such as PAM. It's nothing but it means capillary ischemia of the deep plexus, which is affecting the inner nuclear layer. So when you go back to your retinal physiology, you know that some patients of vein occlusion, central retinal vein occlusion, can also have a compromised blood supply, which is arterial. So you can have a combination of arterial and venous blood supply. And this is because the vein and the arteries share a common adventitia. In this patient, you not only have venous occlusion. This is a 50-year-old female who's hypertensive. You can also see ischemic areas, which are hypopigmented areas in the macula. So this patient probably has a combined arteriolar occlusion as well. As you can see here, the fluorescein angiography shows you knockout of the capillaries, and the disc is hyperfluorescent, as you expect in patients of vein occlusion. And the OCT shows you that there is no macular edema. So you're very happy this patient does not have macular edema. But actually, it's not something to be happy about, because there is hyperreflectivity of the retinal layers, which signifies that there is a lot of ischemia of the retinal layers. This is where we talk about physiology again. Remember, you can develop retinal edema only when you have adequate blood supply. If the blood supply of the retina is compromised, such as in patients with central retinal arteriolar occlusion, you may not have enough blood supply or fluid to cause macular edema. And therefore, this patient is having a prognosis which is actually far worse, because you have not only a high outflow pressure because of venous occlusion, but you have low inflow pressure because of arteriolar occlusion. And this high outflow pressure plus low inflow pressure is responsible for absence of macular edema in this patient. And with time, you have thinning of both the superficial capillary plexus, the ganglion cell layer, and the inner nuclear layer. So you have atrophy and thinning of the retinal layers. And so this is a PAM associated with CRVO and even arteriolar occlusion. Now, patients of dengue fever. This is a patient of dengue fever with microaneurysms. Remember, when you have a vascular disease such as diabetes, anemia, and if you have vein occlusion, dengue, all of these vascular diseases can cause microaneurysms. And this is again very important from the point of view of physiology of the retinal vessels. We know that retinal vessels have very limited autoregulation. Choroidal vessels have absolutely none. And these patients, therefore, can develop vascular abnormalities such as microaneurysms in the eye. Patients of dengue can also develop, ischemia. And this is a patient, if you look at the panel A on the left side, there is an infrared image which shows you a wedge-shaped black color, it's a dark color lesion running from the macula to the optic nerve. This is nothing but a lesion which is called acute macular neuroretinopathy. To make things simple, because now you're a student of physiology for this class, acute macular neuroretinopathy is ischemia of the deep capillary plexus. The difference between PAM and AMN is that it affects the outer retinal layers more. So it's affecting the outer plexiform layer, outer nuclear layer, and it's disrupting the ellipsoid zone, the interdigitation zone. And this is the reason why you have this as a different entity. Now, this is a patient, what I'm trying to show you in case number 4 and 5. Okay, now you can, in the clinic, let's say you're in the clinic and you see and you tell me there is hyperreflectivity, which is involving the outer nuclear layer. So is it AMN? Is it ischemia? It definitely is hyperreflective on the OCT, but is it really acute macular neuroretinopathy? And this is where your knowledge of physiology comes into picture. This is not ischemia. This is not acute macular neuroretinopathy. Remember, the outer nuclear layer has a layer of Henle's fibers. And these Henle fiber layers, as you can see here on this picture, the outer nuclear layer, and just focus on point number 8.2 here, the Henle fiber layer. This Henle fiber layer is a very unique part of the outer nuclear layer. So it is, if you look at the histology, it may be covered in the anatomy lecture, but this Henle fiber layer is anatomically a part of the outer nuclear layer. Okay, but it's quite distinct because it has fibers and which are oriented, which have a definite spatial orientation. So this is the Stills-Crawford effect of the retina. And when you have an OCT scan, which is tilted in a particular manner, in this patient number 4 and 5, patient number 4, you have subretinal fluid. Patient number 5, you have a flat irregular PED because of C and V. You have, an elevation and change in the direction of the outer nuclear layer. So this OCT light, which is incident, has become oblique. An oblique incident light on the outer nuclear layer can show you the Henle fiber layer as a hyperreflective part of the outer nuclear layer. So I'm showing you this slide just to re-emphasize once again that the Henle fiber layer is a layer which has a unique property because it has an oblique orientation in the retina, and it is having a specific spatial orientation responsible for the Stills-Crawford effect, which is the arrangement of the photoreceptors are in an oblique manner around the perifoveal region. This is very important physiologically, and now you can look at the applied anatomy and physiology, how it brings confusion in our clinics, and you can confuse this for ischemia. Now, these are, of course, the parts of the retina and the choroid now accepted by the OCT. Remember, the Henle fiber layer is also very closely associated with the outer plexiform layer, which is hyperreflective. And so this is just a distinct layer anatomically and has been designated separately. When you talk about the photoreceptors, the retinal pigment epithelium has, of course, the rods and connection to the rods and the cones, and the cell bodies of which are present in the outer nuclear layer. And in the inner nuclear layer, you have the cell bodies of horizontal cells, Mueller cell glia, which have structural function, and bipolar cells. And you also have amacrine cells, and you have the ganglion cells. The ganglion cells finally relay all the nerve fibers from the optic nerve to the brain. So this is the composition of the outer nuclear layers, inner nuclear layers, and the ganglion cell layers. Now, these are the synapses that you can see. And the Henle's layer basically has the synapses between the ONL and the INL. So the photoreceptor axons in the outer plexiform layer are known as the Henle fiber layer, and they're obliquely oriented around 350 microns from the fovea. And you have synapses and sperules linking the horizontal and bipolar cells to the photoreceptor layers. So when the light is absorbed by the retinal pigment epithelium, you have the visual cycle taking place in the outer nuclear layer and the RPE. You have the change of rhodopsin to meta-rhodopsin 2 and formation of cyclic GMP into GMP and conversion of this energy into electrical impulse. And thereafter, you have the signal transduction from the rods and cones to the bipolar cells and the ganglion cells. Now, what is a fragmented foveal avascular zone? So I'm taking a jump here to the foveal avascular zone. From the anatomy and the OCT studies, OCT angiography, we all know the foveal avascular zone is a zone of central area which does not have any blood vessels, and it is visible on fluorescein angiography and OCT angiography. But the foveal avascular zone can be fragmented. Now, what do you mean by fragmented? So remember, development of foveal avascular zone is necessary for formation of the foveal pit. and excavation of the inner retinal layers. So this is important physiologically. Measurement of the foveal avascular zone has been evaluated in number of conditions. So we do it in diabetic retinopathy, vein occlusions. Maybe you may have done it as a part of your research projects. And now there are certain parameters such as a circularity index coming up. But 5% patients have microvessels running through the foveal avascular zone in at least one eye. And this is called fragmented foveal avascular zone. Now, this is important because this is a normal a physiological variation where you have blood vessels present within the foveal avascular zone. Now, these vessels do not cause any abnormality, and you can see them on OCT angiography. So they don't cause any abnormality in the functioning of the photoreceptors. So I've included this slide because you may have literature or you may have learned from physiology that in the central foveal pit, blood vessels are always abnormal. That's not the case. You have abnormalities when you have choroidal neovascularization, but foveal vessels or retinal vessels may be normal in 5% population. And these are microvessels. So they are not rare. The visual acuity in these patients are unaffected. And patients with if a patient with retinal disease has fragmented FAS, you may confuse it and you may not be able to measure the biomarkers accurately. So this is something which is a little more advanced. I'm not going into the details for the purpose of this lecture. Now, I'm talking to you about another important physiological thing that happens, and a subretinal or a serous fluid accumulation which happens in disease. So this is a patient of central serous chorioretinopathy. On the left side, you can see the OCT has accumulation of subretinal fluid. This subretinal fluid can also develop in our retina when a human being has no oxygen supply. So when the patient is dead, at that point of time in the post-mortem period, also a patient can develop serous retinal detachment. Serous retinal detachments are common in a number of conditions such as uveitis. You can have it in diabetes, you can have it in central serous chorioretinopathy. Now, the reason fluid accumulates in the subretinal part is that you have either abnormality in the choroid, which is hyperpermeable, or the RPE pump, which removes all the fluid, has failed. So you have an important physiological function of the RPE, which we briefly mentioned before, but you can see it in this patient that the RPE is not functioning and is unable to pump out the fluid, and therefore you have a detachment of the retina, which is a serous detachment. Now, in patients with VKH disease, you can have not only the serous retinal detachment, but accumulation of fluid in the intraretinal layer. And now we call it bacillary layer detachment. You may have heard of this term in the recently published literature, but this is not very different from an intraretinal cystoid space. It is an accumulation of fluid within the photoreceptor layer. So remember, when you have accumulation of fluid in the subretinal space in a subacute manner, such as central serous chorioretinopathy, or when a patient has died in a post-mortem period, the accumulation of fluid in the subretinal space is rather slow and it develops a serous retinal detachment. But when you have an acute retinal accumulation of fluid, such as VKH disease, which is a florid disease, there is an acute inflammation of the choroid and the retina. You have acute accumulation of fluid and it causes formation of pockets of fluid within the photoreceptor layer, and this is called bacillary layer detachment. So this bacillary layer detachment can happen even in TB choroiditis. It can happen in any condition in which you have acute accumulation of fluid. So the important thing that I want to convey is that depending upon the speed and depending upon the level of inflammation, you can have accumulation of fluid in different parts of the retina, choroid, and the different structures. And most commonly, there is a serous retinal fluid accumulation, but if it's very rapid, like in the patient of VKH or in TB choroiditis, you can have development of fluid in the intraretinal cystoid photoreceptor layers causing bacillary layer detachment. So BLD occurs frequently in eyes with uveitis because they are very rapid in onset, like VKH. And it's an important sign which can differentiate it from CSC and other conditions, but you may have some rarely a patient with CSE having a bacillary layer detachment. So with this, I think I am really done. There is no end to the retinal physiology, but I think I can stop now and take any questions if you have. I would also like to thank the entire team of CFS, iFocus, for this opportunity to allow me to present, and I hope I have been able to drive through some important messages. Thank you so much.
Definitely, sir. You explained it very, very well and quite concise yet elaborate, so that kind of puts the point forth. We do have some questions, and I'll take up the questions with
Yes.
Dinesh. Sir, would you like to say something before I take the questions?
So I think that's a fairly exhaustive exposition of the physiology of the retina. And I think there are lots and lots of aspects. So there are bound to be more things which we will leave it to the students over here who are there in the hot seat to ask us their questions. And then we'll see if there's anything more to be picked up. So could you, I can't see the question.
Yeah, they'll come online, sir. Before that, I'll ask a question by Zenith. She said that she would like to know what is the component of SRF.
So thank you, Zenith, for the question. I think a number of studies have looked at the composition of subretinal fluid, but from post-mortem eyes only. You can, of course, do it in vivo. In vivo, you can do it only if you have a patient undergoing surgery for a uveitic condition or let's say a diagnostic surgery. But you cannot definitely have the composition of subretinal fluid studied in vivo, like in a living organism. From post-mortem eyes, we know that the subretinal fluid consists of a number of components which are cellular and acellular. The cellular components include the shed outer receptor photoreceptor segments. It can have some of the RPE, dead RPE cells and some inflammatory cells. The fluid component, which is acellular, has a number of phosphates, electrolytes, and it can have lipid components, and it can have phosphines or those components. So mainly phosphorus related components. It depends on the disease. So if you have a uveitic condition, the composition may be very different of the subretinal fluid versus that of CSA. So there is nothing uniform in this, but it's definitely lipid and fluid. And occasionally, if it's a hemorrhagic accumulation, you can have blood and RBCs as well.
Right, so we have another question.
One second, Rolika.
Yes.
Yes, sir.
In cases of detachment, especially during the surgery, we can collect this fluid and send it for a biochemical analysis.
Yes.
We have done few series of these studies, and then we see more proteinaceous component in this. So this is called sclerin. By the very aggression of sclerin during the surgery, you can identify that there is some regma on the table itself. Means even when you are not locating, if the sclerin is aggresses, then definitely a sign of a presence of regma. Yes,
sir. I'd just like to add on that now recently, in fact, last week, Dr. Retinal ma'am from Arvind, she shared a case with me in which they did a deep sclerectomy for a patient with exudative retinal detachment, and this patient had panuveitis, and they found a lot of proteinaceous material in that, and there were also inflammasomes, caspases, all of these entities. So it depends on the disease. You can have so many materials, proteinaceous material.
Certainly. So we cannot stick to one component. It's rather primarily dependent on the disease process which is involved and while collecting the fluid.
Yes.
Definitely.
Nisha has a question.
Yes, sir. So Nisha's question is that how do we differentiate between outer retinal tubulations and bacillary layer detachment?
So Nisha, for that, you have to go back into the anatomy of the outer retinal tubulation. Outer retinal tubulation arises from the external limiting membrane and the structures above. it's a chronic process. It's not an acute process, and it typically described in AMD, but also now we know it happens in DME, chronic uveitis, any chronic condition. It's not acute. And it has a number of stages of development. So it starts from hyperreflectivity of the outer retinal layer, and then you have curling of the external limiting membrane to form a tubulation. If you look at NFAS, you will find that it's a long tubular structure which is running across the macula. On the other hand, a bacillary layer detachment is an acute process associated with accumulation of fluid in the subretinal space. And it is not a tubular accumulation. It can be of different shapes. It can have no shape at all. It can have entire macular involvement, or it can be a loculated fluid inside. So it's important to understand that there is a difference in the timeline and in the structure. The origin of the outer retinal tubulation is in the external limiting membrane, and the bacillary layer is in the photoreceptor layer itself.
I think itself, usually you'll see outer retinal tubulations in eyes which are having severe retinal degeneration. It's a geographic atrophy. Photoreceptor atrophy is going on in those eyes. And these are like small cartwheels which have formed around them. It's like a small cartwheel around the tree. You're not likely to ever confuse an outer retinal tubulation with a bacillary detachment, where there's likely to be some kind of plasmoid changes also. So in the subretinal fluid there also, you're going to see some kind of hyperreflective areas. So actually, I think maybe in one of the future lectures, we can show you a bacillary detachment and an outer retinal tubulation. They're completely different morphology altogether. So,
and the disease process is also more acute in case of bacillary layer detachment compared to the tribulations where it is chronic. It's not only AMD, in diabetic macular disease, also there can be outer retinal tribulations.
Thank you for answering that, sir. There's another question, which is that what is the pathology of retinal elongation in myopia progression?
So in myopic eyes, we know that the eyes are longer, the axial length is higher. And what happens is that with age, we know the growth of the eye continues up to the second decade of life or even beyond. The axial length can increase. With the increase in the axial length, remember that your retina has to stretch to become a part of and along the configuration to adjust to the growing eye, and so also the choroid. And because of this, what happens is that towards the periphery and towards the peripapillary region, there is an sort of a thinning of the retina, and this leads to weakening of the retina in certain areas, and this includes the peripapillary retina. And that's why you have peripapillary atrophy, and you have additional peripheral retinal problems which are higher in myopic eyes, such as predisposition to certain degenerations like holes, breaks, etc. So they're all because of the stretch effect, because the retina has to stretch and confer to the elongated eye. Sometimes these patients can develop staphylomas, and when you have a staphyloma, it adds to the surface area for the retina to cover, and therefore you have thinning of the choroid and thinning of the retina in order to cover these particular areas. When you have abnormalities in the thickness of the retina and the choroid, it leads to a number of problems, pathologies. This could be choroidal neovascularization, it could be atrophy, it could be damaged photoreceptor function. So these are the things that can happen.
In addition, there can be changes in the vitreous in these patients of high myopia. There can be vitreous schisis along with schisis of the retinal layers as well. And in the posterior pole, there can be an elevation of the retina, though it is because of short growth of retina compared to the rest of the layers of the eye.
Can I add a point here, sir? Yeah. So one of the effects that Anirudh talked about was the Stiles-Crawford effect, which also very nicely comes up in myopic eyes. Such eyes, very often we see even without a pathology, the vision may not be 6/6. As the eyeball elongates, the photoreceptors, which are supposed to in the fovea, supposed to be dead perpendicular to the ray of light, now starts to become more oblique. So when the light falls more obliquely on a kind of a stretched retina, because of the Stiles-Crawford effect, the visual acuity does go down. So the Stiles-Crawford effect also explains very often why high myopes, in spite of having a very good looking retina, can still functionally not be as good as a normal retina.
I
That's
think
because of the
most important aspect of the Stiles-Crawford effect comes in retinal detachment surgery. One reason why people used to prefer to do non-drainage surgeries were because if you let the SRF settle down on its own, the photoreceptors are more likely to settle on their normal position. Whereas when you do a drainage of the subretinal fluid, there's a sudden settling down, and then the angulation of the photoreceptors occurs. And that can take weeks to months for it to reach its normal position. So that is why even after a successful retinal detachment surgery, especially drainage surgeries, it can take a long time for the visual acuity to return to its final position.
Right, sir.
Any other questions?
Yeah, so there's one more question from Farah, which says that what is the retinal peripheral defocus?
What's the peripheral retinal?
What is retinal peripheral defocus?
Yes, Anirudh, would you like to?
I'm not sure what it is exactly, to be honest with you, but I believe it has something to do with the myopic eyes as well. It basically would indicate that in the eyes which are high myopic, they have extramacular atrophy, and therefore you can have peripheral field of vision might be affected and defocused. This could also be again related to the Stiles-Crawford effect, but honestly, I'm not too sure about the answer.
If the presenter, the hot seat occupant, if they can explain what they want, probably we may be able to answer it better.
It's a question from the social portal, sir. So they're not from the hot seat. Right? So yeah.
It could also be as if I try and understand it, it could also be because of the shape of the retina, which is kind of oblate, the cup shape of the retina, the peripheral retina. As Stiles-Crawford effect works there, the light does not fall incidentally perpendicular to the retina there, and that causes the peripheral retinal vision to not be as sharp as the central retinal vision. That's what I understand. And wherein the role of your iris comes in to cut off these kind of lights, which can cause a lot of aberrations to the eye, if that's what they're trying to.
Yeah. I think one more thing, what it does is if you have excessive peripheral retinal defocus, it can lead to a stimulus for myopic progression. It can lead to, because you don't have focus, so the peripheral retina will try to grow further. So it tends to increase the axial length and causes myopic progression.
Right, so another question is that how can we prevent retinal changes in AMD from onset?
What?
How can we prevent the retinal changes in AMD starting from the onset?
I wish we knew. We would be out of business if we did it. But
no. But Anirudh, in this junction, I would like to ask you the physiology of Bruch's membrane, and with aging, what happens? That is more relevant to AMD, and then what preventions and all kinds.
Yes. So thank you, sir, for the question. I think Bruch's membrane is a 5 microns membrane, but it is so important when it comes to the integrity of the RPE and separating the choroidal vessels from the retinal vessels. So with age, the Bruch's membrane tends to undergo a number of physiological changes, which are fragmentation of the Bruch's membrane and increase in the calcification of the Bruch's membrane. Now, once the Bruch's membrane ages, and at the same time, if you have oxidant damage to the Bruch's membrane, it definitely affects the integrity because the Bruch's membrane and the RPE form the barrier, the blood retinal barrier, and these barriers can be affected. So in conditions such as myopia, where you have lacquer cracks, which are essentially cracks which happen in the outer layers, and also in patients who develop choroidal neovascularization with ruptures in the Bruch's membrane, you can have an easy access of the choroidal vessels to come and form the type 2 choroidal neovascularization. And therefore, these patients can develop active CNV with subretinal fluid accumulation. So the Bruch's membrane integrity is also affected in conditions such as Paget's disease, where you have dystrophic calcification. In patients with angioid streaks, you can have, Bruch's membrane, which is abnormal. And these patients can develop complications such as, if the membrane ruptures subfoveally, you can have decreased vision. If there is choroidal neovascularization, you can have decreased vision. So the integrity of the Bruch's membrane, and that's why we call it RPE Bruch's complex. We don't separate RPE from Bruch's because they are one complex, and any damage to the integrity or the barrier can cause choroidal neovascularization. In AMD, you can remember some changes of aging are physiologic. So accumulation of basal laminar deposits and basal linear deposits are physiologic. So these changes are physiologic. You cannot prevent. You cannot become younger. Certain changes of AMD, you can at least reduce the progression by antioxidants. That's why you have the ERED study to decrease the progression into wet AMD. But you can do it only 25% cases. So you can't do it in 100%.
Right. So there's another question, sir, which is why subhilar hemorrhage doesn't clot?
Because it does not have the clotting factors. So it requires, for any blood to clot, you will require to have all the clotting factors. And I believe it does not have a couple of clotting factors. I think it's factor 13, which, if I'm not mistaken, it has some, it follows the intrinsic pathway, remember, so of clotting, and it does not have all the clotting factors. So you will never have blood, even the vitreous hemorrhage, for example, you may not have clotting unless you have an exogenous damage. So if you have trauma and you have vitreous hemorrhage, or let's say you have foreign body entering the eye, you can have clots of blood because the extrinsic pathway of clotting is activated. But by itself, if there is an intrinsic bleed, it will not clot.
Okay, sir. So I don't think this question falls in the physiology category, but there's a question asked by nearly 4 people. And that question is that how do we choose the intravitreal injection site? And what is your comment on it? Yeah, the site, like, how many from the limbus, and when and how and on what basis? This has been asked by 4 different people.
It's more related to the anatomy wala question, but anyway, I'm sure Anirudh can answer that.
So basically, you try to choose superior quadrants. You don't do it inferiorly because chances of endophthalmitis may be higher. In phakic eyes, 4 millimeters is from the limbus is good because that's the area where you have adequate, at least 1 millimeter on either side, you have the pars plana. So you want to go into the pars plana because it's the least vascular area, and that's where you want to enter without touching the crystalline lens. And that's why you choose 4 millimeter. In pseudophakic eyes, you can afford to go 3.5 millimeter from the limbus because you don't have the risk of touching the crystalline lens. And by coming more anterior, you are further reducing the chances of hitting the posterior, the ciliary bodies. So that's why you are staying within the pars plana region. And this is how in aphakic eyes, you go even more anterior because you don't even have the crystalline lens, the intraocular lens. So you can afford to go at even 2.5 to 3 millimeters. But remember, in children, I think up to 2 or 3 years, they don't have a very good pars plana. So you have to be very, very anterior, especially if you are injecting anti-VEGF for ROP eyes, they go 1 to 1.5 millimeters because the pars plana is not developed. And therefore, it's very important, even if you're doing a lens sparing vitrectomy, if you're entering with a trocar cannula, you have to be very, very anterior. One thing on this, yes, sir, please.
No, go ahead, complete your.
One thing, sometimes you can have anteriorization of the retina and the pars plana in some patients who have Stickler syndrome and other syndromes. So in those patients, you have to be careful of where you're entering. The pars plana may be very anterior than what you think.
Okay, so basically the answer is based on the anatomy of the eye. The retina starts beyond the ora. So and where does the ora come? It comes, you have the initial part as the pars plicata, and then you have the pars plana. So you want to be in the middle of the pars plana because only at the edge of the pars plana you have the ora. So which is why 4 millimeters is chosen as the distance where you want to go ahead and give your injection. In a phakic eye, that keeps you away from the lens, away from the retina. You can go up to 3 millimeters when there's no lens without it, because there's no longer a risk of touching. you want to go into an exposed quadrant. So which are the exposed quadrants? The temporal quadrants. Inferotemporal and supratemporal are both relatively exposed. Nasal quadrants are more difficult to approach, but if you want to, you could give from the nasal quadrants also. But two things. One is that it's more difficult to access. And second is all exudates, all discharges and all tend to congregate where? In the nasal aspect. So you'd rather avoid that. So you can give it from the nasal quadrant also, but it's preferable to avoid it if you can. So those are the basic features for why you give injection from these areas. You don't want to go into the pars placata if you can avoid it. So that's but when you go in a neonate, in an ROP, you don't have a choice, because at that time the pars plana is not developed enough. I hope that answers your question.
And in injections of anti-VEGFs, probably superior-temporal is preferred. In implants like Ozurdex and Translon,
I think that's
those inferior-temporal.
A fairly personal thing, because I think a lot of us are giving inferotemporal quadrant as our preferred choice for all anti-VEGF injections. So it's a preferred. It's your own choice. I personally consider giving from supratemporal a small increase in the risk of a detachment, and in ferrotemporal detachment, if it occurs, will progress very slowly, and in supratemporal will progress very fast. So
no, but inferior detachment is more risky.
But anyway, so what I'm saying is the important thing is that temporal quadrants are the ones which are location.
Between superior RD and inferior RD, I prefer superior RD.
Really? I prefer no RD.
Inferior.
Well, you can avoid giving at 3 o'clock, because 3 o'clock can be painful.
Yes, the important thing is not to give at 3 o'clock and 9 o'clock.
Posterior ciliary.
Because you have the posterior arteries there, and you could actually damage them.
Not only that, ciliary nerves will also be posterior nerves, so that it will be more painful.
No, it can also damage it.
Yeah.
So, do we have any other question?
No, sir. Anirudh sir has answered all the questions. Yeah.
And time is also
perfect.
One last something which has a lot of physiological importance and therapeutic importance. Maybe a word on optogenetic therapy, which is based on the information that we have, that ganglion cells can also conduct the light to the brain. So if you can get the ganglion cells to accept the light and conduct, you can pass it on. And that is the basis for optogenetic therapy, which is now being developed.
The basis for that is that the RP patients, RP eyes, patients with RP,
when the photoreceptor
studied, and there is both photoreceptors and bipolar cells are atrophied, but ganglion cells still present. So if you can stimulate the ganglion cells, the onward electrical stimulation can be elicited.
Exactly. So what Babu's told you is the physiological basis for how
in physiology class,
a patient with no photoreceptors, poor bipolar cells, can still see if we can make his ganglion cells the source of picking up the lights. So, which is the basis for optogenetic therapy, which is being developed. And I think that's something which you may be asked as a question somewhere down the line.
Very good.
Right,
so if there's any other, if there's no other question.
Sir, I don't have any of the questions.
Can I add one last point, Rolika, if I have 1 minute? So apart from future, there's a very old test which I just want to stress upon, because I've seen it being asked number of times in physiology papers. It's a test very less used now. It's photostress recovery time. The cycle, the rhodopsin cycle that Anirudh showed, the regeneration does not happen instantaneously. There is a time which is taken for the rhodopsin to reform, and this forms a basis for photostress recovery time, wherein it takes about 25 to roughly, some says 40 seconds for the eye to recover and to start reading letters again on the Snellen chart after being exposed to bright light. and it is more damaged or prolonged in macular diseases, while spared in optic nerve diseases and amblyopia. So this is a very physiological test which is lesser used now, but I've seen it being asked a multiple number of times.
It's better to know.
It's the simplest test that you can do for testing macular function. In fact, if a patient says he has a problem in, and you'll find a lot of patients with macular degeneration or even diabetic macular edema telling you, if the patient says that, then this patient needs to be investigated for a macular disease. So this is a very good point, Ritesh.
And
thank you very much, everybody. I think we had a very interesting session.
Yeah.
And lots of points have been brought out. And I think there is no end to it. So we need to put an end to it. So we will stick to our 1 hour clock.
Right. Right.
The
postgraduates must know that physiology of retina, it comes as a long question and it's a pretty elaborate answer that you'll require to write, including macular function tests. So please make sure that you view the video again to brush up your physiology. Thank you so much, everyone.
Thank you, everyone.
Thank you.
Thank you.
Thank you.
Thank you, Anirudh.
Thank you.
Thank you, sir.
For,
Thank you.
Bye, sir.
very nice class.
Bye.
Thank you. Bye.